This video lecture will cover Chapter 4 of our textbook, The Counseling Process, Establishing a Therapeutic Alliance. And this chapter will give us an overview of how to develop rapport with adolescents in therapy, and also gives us information about how therapy with adolescents looks and feels different than therapy with kids or therapy with adults. A primary task of adolescents is learning to adapt to novel situations and meet new expectations and challenges, while also dealing with peer pressure, self-doubt, and conflicts of interest between peer groups and family systems. And that sounds like a lot. Trying new things while you're feeling doubtful of yourself. Trying new things while you're pulling away from your support network, your family. Trying to find balance between pleasing your peer group and pleasing your family group. These various demands can cause adolescents to feel overwhelmed by trying to balance a sense of independence while still staying connected with their families. When we work with adolescents, we're faced with the need to honor their unique perceptions of the world and to respect their opinions and their views. We need to be aware of and respect this difficult place that they're in, that they are somewhere between childhood and adulthood. Adolescents have distinct rules, values, beliefs, and norms that are reflective of their development. Their worldview is a mixture of childhood and adult cultures. This can cause confusion for them and for the adults in their lives. Because on one hand, adolescents can be childlike and dependent, and the next minute they can be mature and insightful. And they have one foot in both worlds, the world of the child and the world of the adult, where they can be playful, creative, energetic, spontaneous, as a child, with their foot in the world of a child, while they're learning to drive a car, be more responsible for their own education, possibly learn to start paying some of their own bills, dating, finding work. Those are all these adult experiences. So confusing for the adolescent who still needs parenting and monitoring and supervision, even though they may feel more like an adult, and difficult for the parents, confusing for the parents, as sometimes maybe they're hoping their adolescent is behaving more like an adult so that they can back off the monitoring, the supervision, the observation. An example of a way of thinking that is distinct to adolescence and adolescent development is attribute substitution. This involves imitation and identification within a peer group. And so this is something, again, that is unique to adolescent development that can seem very confusing to adults. Adolescents need to borrow or try on behaviors and attributes that they observe in their peers, as they are trying to clearly define their own ways of thinking and behaving, their own sense of self and identity. So they want to try things they see around them, things they may have not been exposed to in their family, different ways of dressing, different music to listen to, different things to watch, different activities in which to engage. Parents may see this as following behavior, that their child doesn't have a sense of who they are. And on some level, they're right. At this age, we don't really know who we are. We're figuring that out. So we're trying on different things, different behaviors, different attributes. And so we find the things that feel like a good fit. And as we find those things, we build those attributes and behaviors that are a good fit, that reflect who we feel like we are. And that is how we develop our sense of self and our identity. We discussed some classic stage theories of development, including Freud, Erikson, and Piaget. I'm going to introduce Laurel Copeland. This theory was developed to describe the characteristics of adolescent thinking, emotions, and behavior as a response to the stress of engaging in developmental tasks. Adolescent idiosyncrasies is what Copeland referred to these as. While Erikson, Piaget, and Freud and other developmental theorists focused on the lifespan, Copeland is really just focused on adolescence, the characteristics and qualities of thinking, emotions, and behavior that occur during adolescent development. The first one being conformism, a shift of identity from family to a chosen peer group. So I find my identity now as an adolescent. I find that more in my peer group and the people I choose to surround myself with, rather than only finding my sense of identity from my family. Preoccupation with self, an intense self-involvement coupled with self-doubt. So a tremendous focus on the self because we're trying to figure out who we are at this age. Who am I? There's a lot of focus. There's also the invisible audience, that sense that everyone's looking at me. And this is coupled with self-doubt. What if I mess up? What if I look stupid? What if I'm doing this wrong? What if people don't like me? Preoccupation with fantasy. Fantasy provides gratification and a means of controlling drives. I think about this in terms of an adolescent who daydreams for hours about the awesome apartment she and her best friend are going to get as soon as she turns 18, as soon as she can get away from her parents. This fantasy allows for an escape, and it also allows for an imagining of what could be. Preoccupation with a need for self-expression, so establishing independence from parents and family. Conformism is focused more on identity, moving your identity from family to peer group. Preoccupation with need for self-expression focuses a bit more on behavior. How do I present myself? How do I express myself? Preoccupation with philosophical abstractions, theories, and ideals. And we talked about that in Chapter 3. As the brain develops, as the cortexes, the frontal lobe, mature, we're able to think more deeply, we're able to examine more abstract concepts and ideals. And finally, a preoccupation with sexuality. These are all things that are characteristic of adolescent development and things that adults may have difficulty understanding or may be confused by. It can be challenging to form a strong working alliance with adolescent clients. There are many factors involved. Whether or not the client is self-referred, or whether or not the client is open to the idea of therapy, plays a huge role, no matter what the age of your client. Because adolescents are seeking independence from the adults in their life, it may make it more difficult to build a working alliance with that adolescent, but not necessarily. The ability of an adolescent to develop a working alliance with you also depends on their relationships with adults outside of the office. If they're able to have healthy relationships with adults outside of therapy, to develop bonds with adults, they're much more likely to do the same with you in therapy. Imagine yourself as an adolescent. How likely would you have been to open up to someone that you didn't know? What would you have needed as an adolescent to feel comfortable opening up to someone, to feel comfortable developing a relationship with a therapist? Research indicates that the therapeutic alliance accounts for 30% of the change in therapy, no matter what interventions, no matter what theory you're coming from. 30% of the change in the progress in therapy is accounted for by the therapeutic relationship. When we work with adolescent clients, we have to honor their experiences, their perceptions, and realities in order to enter their inner world and to assist them to make a lasting change. So think back to some of your first classes in the program, learning how to be empathic, learning how to put yourself in the world of the client. We think about Carl Rogers and person-centered therapy and his belief that we have to be able to enter the client's world. For some therapists, because we are adults, it may be more difficult to do that with adolescents. We have to honor their unique ways of thinking and feeling. And we also have to know that no matter what population we're working with, we have to balance the importance of the therapeutic relationship with the use of evidence-supported interventions. We can be using the most up-to-date, highly researched interventions with a client, but if we don't have a therapeutic relationship, progress will not be made in therapy. Focusing on the adolescent and not the problem. Adolescents often present for therapy because their symptoms are problematic for the adults in their lives. This means that treatment for adolescents might not only be problem-focused, which is a problem in and of itself, but can be focused on someone else's view of the problem. When we only have the adult's perception of the problem, the caregiver's perception, we only have part of the story. We need to give the adolescent an opportunity to share his or her own perceptions of the problem, and that will allow us to see the problem from a different perspective and will allow us to see the problem in a more holistic manner. While focusing on the problem can be a necessary area of therapeutic work, we also need to be cautious about accepting the behaviors that we see on the surface, the behaviors that the adolescent chooses to present to us, or behaviors that are reported to us by others, as this could cause us to miss the adolescent and fail to meet his or her needs. It can cause us to miss the full picture of what's going on. We have to focus on the problem, but we have to find balance because we also have to focus on the client's strengths, abilities, and resources. At the end of my intake, the way I wrap up is I ask the parent, what is your child good at? What makes them special? What do people love about your child? We've already spent a good deal of time in that appointment talking about the problems, talking about flaws, talking about areas we need to work on and improve. It's important that we acknowledge the given fact that there are positives. This adolescent has strengths and resources. And this question actually can give me a lot of information. For the most part, it gives me a list of what makes this adolescent special, what they think about themselves, and what their parents think about them. If we don't find a balance to focus on the problem, but also focus on the positive qualities, if we only focus on what the parents report to us, we risk misdiagnosing the presenting problem, and we risk underestimating the adolescent's ability to be an active participant in treatment and to bring positive qualities and resources to treatment. Communicating the adolescent's views to others. So when we work with adolescents in therapy, we take on the role of translator. We're uniquely positioned to help interpret both the worldviews of the young people and of the adults. And then we can transmit the information between the groups in a way that allows for understanding and relationship building. And some of this is facilitating communication between the adolescent and the caregiver. Some of this is psychoeducation for the parents, for the caregivers, about how an adolescent thinks, about unique characteristics of brain development in adolescents. Why are they behaving this way? Why are they thinking this way? We have to be able to develop rapport and trust with both the adolescent and the caregiver. And I'm going to talk a lot about balance in this video lecture. When working with adolescents, we have to find a balance and the desire to take a directive approach and give advice, with the need to offer acceptance and empathy. What I know is that the adults in this adolescent's life, the caregivers, the teachers, coaches, aren't taking a directive approach. They're giving advice and recommendations. They're laying down expectations. They're putting consequences in place if necessary. So that area is taken care of. As an adult, I can be someone different. I can have a different relationship with this adolescent. And I can offer acceptance and empathy and help them make their own decisions. So I'm reluctant to give a lot of advice and take a very directive approach with my adolescent clients. If I feel an adolescent is going to engage in risky behavior or behavior that could be unsafe in some way, I may get more directive. I may get much more directive with them. I may get more in the mode of giving advice or offering recommendations. But for the most part, I'm trying to be someone different in their life and helping them learn how to relate to adults in a different way. Recognizing feelings. Young people often lack the verbal ability to communicate their inner world. While they can experience a wide range of emotions, they can't always articulate them. So we must be able to both understand the perceptual world of the adolescent and also provide information back to them at a cognitive and emotional level that is accessible to them. So we have to hold information about brain development. We have to hold information about unique ways of thinking for adolescents, unique ways in which they perceive the world. And we have to be able to enter the world of our adolescent client. And then we need to be able to take all of that information and translate it back for them at a level that is accessible to them. Communicating feelings to adolescents who have limited vocabulary or emotional expression means we have to communicate in a language that they can understand. This is one of my favorite quotes for therapists and for parents. Asking questions in therapy would be so helpful if anyone ever answered them accurately, but no one ever does. In therapy, or as a parent, when we use questions without being mindful, without being intentional, those questions can be harmful to relationship building and the counseling process. When something happens with the adolescent in therapy, when the parent gives you a report of what happened over the past couple of weeks, our gut reaction may be, "What were you thinking?" or "Why did you do that?" This can feel pretty accusatory and judgmental. And most adolescents, most any of us, would respond to this from a defensive position. And what I tell parents, and what I have to remind myself as well, whether I'm acting as a therapist or as a parent, we want to ask kids why. Why did you do that? Why did you stay out late and break curfew when you knew you would get grounded? Why? What I tell parents is that's not a helpful question, because here's the answers you're going to get for that question. One being, I don't know. And honestly, your adolescent may very well not know why or how they came to that decision. We know a little bit that their brain development played a role in that, maybe some dopamine played a role in their decision making, but they don't know why. Or they know why, and they say, because I wanted to. I wanted to stay out late with my friends. Neither of those answers is helpful or satisfying or enlightening for the adolescents or for us as adults. And so what we're going to do is use our questions intentionally and try to help the adolescent explore what was happening. What were you feeling? What were you thinking? What did you think would happen? What do you think the possible outcome was? But when we focus too much on questions, we also tend to direct the session away from the adolescent's agenda, what they want to talk about, what's important to them. And we also tend to focus on thoughts and behaviors rather than on emotions. And when we ask too many questions, or we ask questions in an unintentional way, we can make our client feel pressured to come up with some kind of an answer. Limits and boundary setting. We have to balance setting appropriate limits in therapy, even as we encourage our adolescent clients to explore. So in this relationship, I'm a different adult. I'm not a parent. I'm not an authority figure. So I'm going to let my client explore and try new ways of interacting, new ways of communicating. They're also trying to be more independent and find out who they are. And I want them to do that, but they also have to have limits. Limit setting can be one of the more difficult skills to master, causing discomfort and concern that setting limits will compromise that therapeutic alliance. And so in my therapy office, I really don't have a lot of limitations. For younger kids, I have 2 rules. The rules are we have to pick up what we get out, and we can't break things. I haven't needed more rules than that to this point. The primary limit I put in place for adolescents is that they're not allowed to use derogatory language and at another person in session. So I want them to know this is a safe place where you can share your thoughts and feelings freely. Adolescents in my sessions, for me personally, they're allowed to curse. However, they're not allowed to curse at a person in the session. A parent or me, they're not allowed to direct derogatory language or cussing at an individual. When you work with adolescents, you'll want to challenge yourself to find your own comfort level with certain topics. That may be sexuality or sexual behavior. That may be curse words. You want to choose those limits and set them for the adolescent's comfort, not your own comfort. The ACT approach to limit setting can be used in therapy sessions with an adolescent, but also can be used as psychoeducation to help young people know how to be assertive and set limits with other people in their lives. The steps are: acknowledge the feeling with an empathic reflection of meaning or emotion or an observation of nonverbal behavior. I can tell you're feeling really frustrated with me right now. Set a limit, but I need you to stay here in the room with me. Offer an alternative choice. If you want to take a break in the waiting room for a few minutes, you can. And when you set this limit, you can also use choice language to give the adolescent a sense of autonomy, a sense that they're in charge of what's happening. You can choose to talk or not talk in here. You can choose to take a break and come back to session and continue talking, or you can come back to session and we can sit together. Assigning positive intent. Parents and other adults in the adolescent's life can assign negative intent to their behavior. For instance, assuming all argumentative behavior is defiance and disrespect, whereas some argumentative behavior, which should be done in a respectful manner as possible, but is an expression of the adolescent's developmental stage, an expression of their attempt to separate themselves from their family, to find their own identity, and to become independent. Or assigning negative intent to their adolescent who copies their friend's behavior. Well, she's a follower. She can't make her own decisions. Well, no, this is your adolescent trying to find out who she is. And these are safe ways, by the way. Let's assign some positive intent to this. This is a safe way for her to figure out who she is by buying clothes like her friend or listening to music like her friend. When we're able to reframe the client's behavior as meeting a need or asking for help, we're better able to act with compassion and support versus irritation and reprimand. And again, reminding ourselves that we're not their parent. We're not an authority figure. I tell adolescents and kids, I'm a unique adult in your life. I get to hear all the bad stuff and the good stuff. I want to hear the good stuff, but I get to hear all the bad stuff. And I don't have to lecture you, and I don't have to give you a consequence, and I don't have to ask you a ton of questions about it and give you a hard time about it. I just listen, and then I help you solve problems. When we model this response for parents, when we model assigning positive intent, or let's just say balanced intent, we can help them also respond with compassion, or a balance of compassion and irritation. So yes, your daughter is quite argumentative, and that can be a problem. And she needs to know how to pick battles and communicate more effectively. But this is why this behavior is occurring. So it doesn't have to be a wholly positive intent, but we can help parents take a more balanced view of certain behaviors that their adolescent exhibits. I'm going to transition now and talk about a book called No Talk Therapy for Children and Adolescents by Martha Strauss. It's one of my favorite books to share with students and supervisees who are working with kids and adolescents. This book really helps us understand why we might need to take a different approach when working with adolescents in therapy. A developmental basis for no talk therapy. Cognitive development. We want so much for kids to talk with us that we sometimes overlook the possibility that they don't really know how. And this again is true for therapists and for parents. When kids say, I don't know, they really might not know. As frustrating as it can be to hear. Sometimes our adolescents don't have the words. They don't know what they're feeling or thinking, or if they do know, they don't know how to communicate it. Adolescents may still use concrete operational thought, having not yet developed formal operational thought. So think back to Piaget. This is his framework. Theory of cognitive development. Concrete operational thought is elementary school age and early middle school age. Black and white thinking. No gray area. Formal operational thought is coming online in middle school and high school, but also in young adulthood. Think about chapter 3. All the parts of the brain are not working together at this point. Different parts are doing different things. And so we don't go from concrete operational to formal operational overnight. That formal operational thinking, that is gray area thinking. That is being able to take into account nuance. That's being able to be abstract in our thought. Adolescents live in the present and may struggle to learn from consequences they have not experienced repeatedly. Physical development. Even when adolescents appear physically mature, they're limited by social immaturity and lack of life experience. So it's important to remember when you have a 13-year-old who could pass for 16, or you have a 16-year-old who could pass for 20. So even when adolescents can look like adult versions of themselves, they're still limited in their development, in their emotional, social, behavioral development. We have to be careful not to expect too much based on how the adolescent appears, based on how old they appear to be. Emotional development. The inability to put negative feelings into words explains why some adolescents have difficulty talking directly about intense experiences in therapy. So again, if we go back to this concrete operational to formal operational thought, this is in transition, that there may be times when adolescents can't find the words to express negative emotion. There's a tendency for them to distance themselves from strong negative feelings because those feelings are uncomfortable. For adolescents, talking about negative feelings is not the norm. Sitting around with their peers, they're not talking about sadness and depression and worry. They may be confused by strong emotions, and they may fear being overwhelmed by their emotions. And this does go back to that cognitive development. They may be able to feel those emotions and label those emotions, but they might not have the cognitive development to express or communicate or process those emotions. We shouldn't assume that adolescents are being defensive or resistant when we try to talk about past emotions. Adolescents live in the present, and we often want them to talk about the past. They may not be able to tell us about the past or tell us how they felt when something happened. And social development. As I mentioned earlier in the video lecture, if adolescents struggle with adult relationships outside of therapy, they're likely to reenact those relationships in therapy. And if this happens, if you can get past this with an adolescent, you can model for them, you can provide a corrective emotional experience, that you can have a positive, healthy relationship with an adult, because we're doing that right now. You have at least one, which means you can have more. Assumptions of talk therapy. Many therapists may operate under 5 child or adolescent unfriendly assumptions derived from treatment for adults. Those assumptions being that talking is the most natural way of sharing information, talking about problems leads to solutions for those problems, getting in touch with bad feelings is beneficial, talking in therapy leads people to have more control over their lives, and finally, the prospect of feeling better through talking is inherently motivating. So let's look at those assumptions in terms of no talk therapy. Talking to adults is not necessarily natural for adolescents. A prolonged conversation, especially about thoughts and feelings, with an adult is not the norm. For adolescents, talking about problems can make the problems feel bigger. The distinction between having problems and being bad or being a problem is often blurred. Discussion of problems can be redundant and overwhelming. Don't confront me with my failures. I've not forgotten them. And this is something I always keep in mind, and I try to help parents understand as well. We know what the problems are. Your adolescent knows what the problems are. They know their flaws. They know when they've messed up and how they've messed up. So let's talk about something different. Let's talk about what they've done well. Let's talk about their resources, their abilities. We want to balance that problem focus out with a focus on what the client has done well, can do well, is good at. Continuing with assumptions of no talk therapy. Getting in touch with bad feelings can make adolescents feel miserable. Dwelling on emotional content can be frightening, annoying, and overwhelming. We're asking them to be vulnerable, and they're already vulnerable. So many times, adolescents are very well connected with their negative emotions. They feel them, they know that they're happening, but they may not be able to communicate or process them. Asking them to dwell in this area, in this bad feeling, can seem cruel. And this all goes back to balance. We can't avoid talking about sadness or anxiety, but we also don't have to hold our clients in that space. We can visit it and then move away. We can give them coping skills before we take them to that place. Therapy talk doesn't give kids more control over their lives because, frankly, adolescents don't have a lot of control over their lives. By not participating in therapy, that may be a way they exert control in their lives, by refusing to comply with another set of adult rules and expectations. Remembering that some adolescents do not come to therapy voluntarily, and some may not even know what therapy is. But again, giving adolescents a share in the process of therapy can distinguish therapy from different parts of their lives. And finally, change is not inherently motivating for kids. For adolescents who are living in the present moment, the notion that the pain of therapy will be worth the outcome has little practical value. Also, adolescents may not believe that they need to change or get better. Therefore, there's not motivation to work in therapy or to engage in therapy. The change that needs to occur may not be the adolescents. It may in fact be the parents who need to change.